Hello friends, welcome to Hip and Knee Clinic, and today we are going to discuss about acromioclavicular injury, that is the acromioclavicular joint. So today we will discuss about, so first we start with anatomy. So acromioclavicular joint is between the acromion process of the scapula and the lateral end of the clavicle, and there are few ligament which is very important while treating the acromioclavicular joint. So first ligament is AC ligament, that is acromioclavicular ligament, which connect the lateral end of the clavicle and the acromion process. And strongest ligament is the coracoclavicular ligament, which has two parts. One is the conoid and another is trapezoid. So these are the coracoclavicular ligament, and this is the acromioclavicular ligament. And AC joint protect the neurovascular structures and help in the weight lifting. So what are the mechanism of injury? One is the direct injury and another is indirect injury. Indirect injury occurs due to fall on the outstretched hand. Associated injuries are the neurovascular injuries, rib fractures, and clinical features. Patient usually present with the bump over the lateral end of the clavicle and pain and unable to lift the shoulder or limited restriction of movement. And radiographic evaluation is the X-ray of both the AC joint, that is a chest width including both clavicle and acromioclavicular joint, which help in evaluation and decide in classification of the injuries. So these are the classification for acromioclavicular joint. There are 6 types, and first is the ligament stretch, that is the AC ligament is stretch. There is no tone in ligament, so it can be treated conservatively. And second is there is a rupture of AC ligament, but coracoclavicular ligament is intact, and it also can be treated conservatively. Type 3 is there is a complete rupture of the AC and CC ligament, and there is a superior migration of the lateral end of the clavicle. So in high worker who require the AC joint, so in that patient we can do operative management. There is a chance of conservative treatment also. Both have almost equal result depending on the patient function. And this is the fourth one. There is a posterior migration of the clavicle, and in fifth type there is a superior displacement of the lateral end of the clavicle, and there is a tenting on the skin. And sixth is there is inferior migration of the clavicle. So these four, fifth and sixth are treated operatively, and we can repair the ligament, and we can put the hook plate also, and we can pass Marcelin tape beneath the coracoid and tie with the clavicle. So this can come down and we can treat it operatively. So management is conservative versus operative. In conservative management, we will usually give arm pouch to support the lateral end, and this will continue for 4 to 6 weeks. So ligament get chance to heal, and we'll start the mobilization of the hand, wrist, elbow and shoulder joint progressively. In operative management, already we discussed in type 4, 5th and 6th need to be operated. In type 3 there is a role of conservative as well as operative depending on the patient's expectation. So if you have any query, you can put in the comment section. Thank you very much.